It will take a minute for us to go Facebook Live. All right. So can you share that link where we are live so that we can put that on the Spurs Physios page? Because my Facebook Live is taking me to my page and not this page.
So please share a link on chat so everyone can see.
Just the request is सौरभ जी ये जो लिंक सर ने इस चैट में शेयर किया है ना वो आप स्पर्श फिजियो पे डाल दो so people who visit Physio Spurs to watch it live on Physio TV. For some reason वो जा नहीं रहा है. We don't want to spend time.
Rakshita, I'll join you in a minute. My patient for consult has called.
Okay.
Okay, as soon as I finish, I'll join.
Okay. It's 11.
Yeah. 1 minute.
Okay.
Yeah, we can start. So good morning, welcome everyone to this session. Would request Dr. Rakshita to start the session.
Good morning everyone and warm welcome in our first webinar. I'm Dr. Rakshita from Physio Spurs, treating kids from 2013 in Jaipur. And today is our first webinar and I'm glad it is Dr. Taral Nagda. He's a very good ortho as well as a very good human being with a very big heart for his work and passion. And I'm really happy to introduce him first. He's a pediatric orthopedic surgeon. Almost you all know about this. He's attached with many hospitals, SRCC Children Hospital and Hinduja Hospital, Sefi Hospital, as well as he's Director Jupiter in CP Clinic and Director Jupiter in a Gait Analysis Lab. He's a special interest in pediatric ortho, hip replacement, CP, deformities. He's interested in that, as well as he is doing non-orthopedics. He's interested in gadgets, farming, reading, and many more things. With him, we can see many things, because he is one of the person who have lots of interest. And when he is talking to the patients and the parents, it's always learn something new. And I hope you all enjoy today's session because of him. Thank you so much, sir, for coming, and welcome you here. And now I want sir to start.
Absolutely. So thanks, Dr. Rakshita. Thanks. Please stop sharing your screen.
Yeah.
So this talk is for all of us who are involved in the management of cerebral palsy. Dr. Rakshita, I hope the screen is seen to everybody. You're just checking. And is my sound clear?
Yes, it is, sir.
Okay, and I hope my face is also seen. So, so this is thinking smart, because a lot of people manage cerebral palsy in a way it should not be managed. And it should not be definitely managed like a poliomyelitis. It is a different entity. It should not be managed like other spastic condition. Each child with cerebral palsy is special and requires a very, very special management. And that's why this session is there. It's meant for parents, for physiotherapists, for orthopedic surgeons, for NGOs, anybody who's interested in looking after children with cerebral palsy and interested in that care. I'm sure would benefit from what we are going to discuss in next half an hour or so. And then we'll have this session open for discussion, so people can ask questions on the Facebook. Those who are watching on Facebook, people can put in the comments on YouTube, and people who are present here, they can ask questions by typing in the chat box. People who are on Zoom, it's a request that when the talk is going on, if you have something to say, please type it in the chat box, but mute yourself so that we don't disturb everyone else who is watching this program. So when we think of winning, we think of a lot of things. Mental status of a team which we want to win is completely different. So cerebral palsy, the word CP, a lot of people feel that CP is pessimistic. CP means curiosity, CP may be trouble, CP are problems, but it's really not so. Cerebral palsy can also mean compassion and passion. Cerebral palsy, CP can also mean capable person. And a lot of capable people are here. Ritika is here, person with CP, but she has really made it to the top in her life. So some of the things which I want to share. And before I share, I want to share some of the pictures from this Children's Orthopaedic Hospital, where the first cerebral palsy multidisciplinary clinic started in our country. Dr. Medni Pade was part of this for some time. Dr. Mullah Firoz, whose birthday on 3rd October we celebrate as National CP Day, was the first director of this institute. And now this institute has grown into a very big children's hospital in Bombay at Haji Ali, what we call as SRCC Children's Hospital, managed by Narayana Health. And this is the place where I work, and with a team we do a lot of cerebral palsy work. I also travel all across, work with a lot of therapists, rehab people, and together we manage as a team, along with parents, this whole burden of cerebral palsy. Now, what is cerebral palsy? Cerebral palsy kya hota hai? It is estimated that around 18 million people worldwide have cerebral palsy, and among these, around 25 lakh जो बच्चे या adults भारत में हैं. So there are a lot of people with cerebral palsy, children, adolescents, young adults, adults with cerebral palsy who need to be taken care across the lifespan. So what happens in cerebral palsy? One must understand that cerebral palsy is not a disease by itself. It is not a disability. Cerebral palsy is a condition. Like how you have fever, how you feel hungry. Similarly, you have cerebral palsy. It's a condition. And cerebral palsy can be caused by many other problems. So a child who is born with low birth weight, or child who is preterm, if there is less oxygen to a neonate called as neonatal hypoxia, if there is a difficult delivery, and if there is bleeding in the brain, when the child is born, which is known as intrameticular hemorrhage, child can have cerebral palsy. कई बार बच्चों को जन्म के बाद इन्फेक्शन हो जाता है, एनआईसीयू में रखना पड़ता है, तो इन बच्चों को भी सेरेब्रल पॉल्सी हो सकता है, क्योंकि उनके जो ब्रेन में एक जो एरिया रहता है वो हलन चलन का काम करता है, मूवमेंट्स कंट्रोल करता है, दैट कैन नॉट वर्क प्रॉपर्ली. And these are the children who get cerebral palsy because they cannot move their hands. Some of them cannot move their legs. Some of them may not have the trunk control and the neck control. Some of them may have speech problems. Some of them may have vision problems. So different problems they may have, but they are all included under one umbrella. So cerebral palsy is an umbrella which has a lot of conditions which are put together. Now, when we talk of cerebral palsy, a lot of you will wonder that if cerebral palsy is a neurological problem, why is an orthopedic surgeon talking about cerebral palsy? Is it cerebral palsy or orthopedics ka kya vasta hai? So this is what I want to sort of, clarify, that the primary problem in cerebral palsy is an injury to the brain. But what happens is this is something we have no solution to. There are no answers. People have tried various sort of therapies. There are a lot of people who also go for stem cells, but in today's date, there is no proof that stem cells has any result for treating brain injury in cerebral palsy. So I can say that, we cannot treat the cause of cerebral palsy, but we can make the child better. And how we can make the child better is by, preventing or treating its secondary problems. So when child has a problem in the motor cortex, there are two types of problems which occur. One is that which happens is the brain which controls the spinal cord, that control becomes less. The spinal cord is like a hot oven and brain is like a ice cold water. The spinal cord, which is like a hot oven, when brain cannot control, there are a lot of impulses which pass through the spinal cord, and that gives rise to spasticity or hyperreflexia or clonus. And these are known as positive features of cerebral palsy, not positive in a way a psychologist would understand, but positive in a way that they are giving rise to increase in tone. Now, similarly, you have negative features of cerebral palsy because of loss of control. And children with cerebral palsy have poor grip, they have poor muscle power, poor balance, they get tired very easily. Some of children with cerebral palsy also have sensory problems, though CP is recognized as a motor issue. Dr. Medni Padde would tell us that there are a lot of children with cerebral palsy where sensations are affected, and that's the reason they may be walking on toes or losing balance. So these are negative features of cerebral palsy. Negative not in a way of a psychological issue, it's not a negative in that way, but negative meaning absence of something. All right. And these are known as secondary problems. And when a child has tightness and the child is growing, it generally needs to muscle shortening. And that's one of the secondary effects of cerebral palsy, which a therapist, orthotician, orthopedic surgeon, physical medicine and rehab person, all of us need to treat that together. And if we don't treat that, then tertiary problems start. And tertiary problems are in form of joint contractures, joint instability, weakness of muscles, over-lengthening of tendons, loss of liver arm, loss of confidence. And these are all tertiary effects of cerebral palsy, and which also, need to be treated by a team. And mainly here, muscle and bones are under focus when we are treating secondary and tertiary effects. So cerebral palsy जो है कई तरीके का हो सकता है. Unilateral, यानी एक बाजू, one leg and one hand is involved, and that can be cerebral palsy. Both legs are involved, that is known as spastic diplegia, and that is also cerebral palsy. And there are some children, unfortunately, have involvement of the whole body. It is, sometimes wrongly called as quadriplegia, but it is a whole body involvement. So you can have unilateral cerebral palsy, bilateral cerebral palsy, or cerebral palsy with whole body involvement. And I want to ask people who are here, by show of hands, what is happening here. Do all spastic children have cerebral palsy? That's the question. And you can type in the chat and tell me, what do you feel? Do all spastic children have cerebral palsy? If you feel true, then type true. If you feel it's false, then type false. And, yeah. So people are feeling that all spastic children do not have cerebral palsy. And I'm going to talk about this when we start off, that not all childhood spasticity has CP. And I'll give you two examples here. We have two children here. On the left, there is a 12-year-old boy. He was treated as a known case of cerebral palsy, very intelligent, had good memory, but had weakness in the hands, spasticity in lower limbs. And this child actually did not have cerebral palsy. On the right side, you see a girl who is 10-year-old, was born normally, was walking well till 3 years age, but then started walking, having problems with walking. Her younger sibling, her younger sister also has a similar problem. So in these two children, they don't have cerebral palsy. On the left, this child had what is known as compression of the cervical spine and had cerebral palsy. And that's why he was walking like this. On the right, this girl had hereditary spastic paraparesis, a genetic condition where spinal cord is involved. And then these children have tightness of both lower limbs and sometimes upper limbs. So completely different things, and they need to be treated differently from cerebral palsy. The child on the left actually had to have urgent surgery on his neck to treat his neck. The child on the right, we referred to a neurologist and started on medications and therapy. So they have to be treated differently. So first sort of a rule I'm going to tell you is that don't assume that a child who's walking with spasticity has cerebral palsy. Now, the second question which I'm going to ask to everybody and to think about is that why do children with cerebral palsy get deformity? Now, the options are, do they get deformity because muscles are tight right from birth? Is that so? Please keep typing on the chat so that I know. Number two is spastic muscles undergo contracture and shorten. Is that the answer? Or number three is the muscles under tension do elongate as well as with the bone as the child grows, and that causes contracture. So please type in the chat and I can see what people are typing. Type 1, 2 or 3, whatever you feel is all right. And then we will get answer in a short while. So the answer is that deformities in CP happen because a muscle under tension cannot grow as much as the bone. So if you see all these deformities or contractures, they don't represent a contracted muscle. But what happens as the bone grows, the muscle doesn't increase in length at the same speed. Muscle increases in length, but not at the same speed as the bone. So hence, if the femur grows and hamstring doesn't grow, the knee will have flexion deformity or a contracture. So cerebral palsy में जो joints के अंदर contracture होते हैं, उनकी वजह यह है कि जो स्नायु हैं इन बच्चों में वो हड्डी की तरह आगे नहीं बढ़ सकते. They cannot elongate at the same pace. And it's very important, that's why that therapy should be started very early in life. Early recognition and early intervention are two important aspects of treatment of cerebral palsy. जल्द जांच और सही इलाज ये बहुत ज़रूरी है cerebral palsy के लिए, क्योंकि ये जो मसल्स हैं उनको शॉर्टन होने से बचाया जाए, मसल्स को स्टिमुलेट किया जाए, मसल्स को स्ट्रेच किया जाए सही से. और फंक्शनल थेरेपी, मैंने डॉक्टर मेदनी उपाध्याय और तस्य रक्षिता मैम दोनों को देखा है कि कैसे फंक्शनल थेरेपी से वो मसल को लूजन करते हैं और उनका एक उपयोग करा के लेते हैं डे टू डे एक्टिविटीज के अंदर, जिनसे ये मसल की ग्रोथ होती रहे और मसल का पावर और कंट्रोल भी बना रहे. सो दीज आर वेरी इंपॉर्टेंट एस्पेक्ट्स ऑफ थेरेपी. गिविंग स्टिमुलेशन, doing just stretching, massage, that's not the therapy. That's not going to increase length in the muscle or improve the control. The therapy in cerebral palsy has to be very specific. And if it's done specifically and with the right purpose, it will sort of give rise to improvements. So if you see 3 children here at different age groups, all the 3 have different issues with walking. The first child here is walking on toes, but he's walking on toes because he has primary problem, which is spasticity. He does not have contractures. This child does not need any surgery. This child doesn't even need Botox at this period. He requires his good therapy. He will require orthosis. He doesn't still have good balance. So, one should not hurry up with treatment. In these patients, one must hurry up with rehabilitation and therapy, but no need for any chemodenervation, botulinum toxin injection, surgery in this child. At a younger age, it should really be prevented. Now you see a second child, he's also walking on toes, but he's walking on toes because of muscle shortening, relative muscle shortening. And in this child, just taking care of spasticity will not help. Here you have to elongate the muscles. As he grows, through functional therapy, the muscles should be kept stretched so that they go hand in hand with the bones. And in some cases, after consulting with the therapist and the entire team, we do elongate at the muscle level, not at tendon level. A judicious muscle elongation is done so that the heel can come down, so that the knee can become straight. The third case has a lot of joint contractures. The foot is externally rotated. This is an older child who has liver arm problem. And in this child, orthosis, strengthening exercises, and correction of liver arm problem, makes the child to walk better. So what happens in cerebral palsy is problems can be same, but depending on the cause of that problem, the treatment will change. The child who is walking on toes in a very young age, when there is spasticity, we may suggest them spasticity control. And one of the treatment is botulinum toxin at that age group. When the child becomes little older, we may suggest muscle lengthening. And when child still gets older, a bone surgery with plates and screws and liver arm correction may be suggested. So what works for a 5-year-old child may not work for a 7-year-old child. What works for a 7-year-old child may not work for a 12-year-old child. And this is very important to understand by everybody who is managing cerebral palsy, whether it's parent, therapist, orthopedic surgeon, this has to be understood. And this is how cricket or cerebral palsy इन दोनों में बदलाव आता है. क्रिकेट में 3 स्टंप्स हैं, आप किसी भी स्टंप को हिट करेंगे, बैट्समैन आउट हो जाता है, रन आउट हो जाता है. यदि सेरिब्रल पॉल्सी के जो क्रिकेटर है उसको आउट करना है, तो तीनों में से जो स्टंप सही है उसी को वार करना होगा. यदि बच्चे को स्पास्टिसिटी है तो स्पास्टिसिटी का इलाज करेंगे, शॉर्टनिंग है तो शॉर्टनिंग पे बॉल डालेंगे, और लिवर आर्म प्रॉब्लम है तो उसका इलाज करेंगे. So I hope these 2 things are clear. Let's move on to the third thing. And as we move on, people still can ask questions in the chat box. We will be seeing it from time to time. And if there are questions, we can take those questions and answer them. So the third thing I want to check with people is that in cerebral palsy, क्या होता है? Hip joint, knee joint और ankle joint अपने आप में अलग-अलग से काम करते हैं. They work independently and have no dependence on each other. That's the first choice. Or there is interdependence between hip, knee, and ankle. And if there is something wrong with knee, it can affect ankle. Something wrong with knee can affect hip. Something is wrong with hip can affect knee. So which of this is true? And please answer in your mind. And I'm going to come out with answer in a short while. So answer is that there is great degree of interdependence between ankle, knee, and hip. Not only that, there is a great degree of interdependence between left and right side. And there is great degree of interdependence between trunk and the hips, and hip and the knee and the ankle and ankle and the hip. So the whole child has to be evaluated, in total. So I'll give you an example here. This is a child who is walking on toes because of calf tightness. So this is known as true equinus. No ambiguity here. He has calf tightness because of which he is walking on toes. Now you have another child who is also walking on toes. And he's walking on toes not because his ankle has any problem. He's walking on toes because his hamstrings are short, which are pulling the knee into flexion. And because the knee goes into flexion, the heel is lifted off, even though there is nothing wrong with the ankle joint. And in this case, if you treat this child walking on toes with calf surgery or calf Botox, you will fail miserably. This child will stop walking. Here, the problem is in hamstrings, and knee has to be addressed by therapy, by casting, by Botox, or by surgery, whichever way the child requires it to be done. Now, the tricky situation comes here. This is a child who has actually equinus, but he is walking, with plantigrade foot because the knee has gone back and gone into recurvator. घुटना इसका पीछे चले गया है. So what appears from this thing, this whole analysis is that how a child will walk with ankle actually is determined by his position of the knee joint. If knee is straight, the ankle will show its true colors. If knee is bent, then ankle will appear to be in equinus. Okay, even though ankle is normal. If knee is in recurvatum, then even though the ankle is in equinus, it will appear to be plantigrade. Okay, so one must look at the knee joint when we look at the ankle. And if you can see here, this child is walking on toes both sides, but the knees are bent, and this is known as apparent equinus. Here, one way we can check that is by giving the child A4 and seeing. With A4 also he will walk on toes. So it means that the problem is in knee. This child requires thorough evaluation and may require Botox or surgery for the hamstring. Now, this is a child. On the other hand, you see that his foot is plantigrade, but the knee goes back. And this is the child who requires, management of calf with therapy, plaster, splints, maybe Botox or surgery. And we don't have to treat the knee joint actually. So closer watch is required in many of the patients. This is a child who is walking with knees bent. And here, by gait analysis, we know that hamstrings are tight. And here, lengthening hamstring or taking care of spasticity of hamstring will help. But in this child who is also walking with knees bent, this is because of trunk turning forward and secondarily tightening hamstring. Here, hamstring, if they are lengthened, this child will stop walking and will require walker forever. This child actually requires treating his trunk balance, opening up his hip flexors, in some way, and then he will improve. So the two children walking in similar way, the management can be completely different depending on what is happening to the pelvis. So the perspectives differ. Nazariya badli hota hai. So if you see a person here who is on the island, काफी महीनों से वो एक टापू के ऊपर है, किससे मिला नहीं, और सडनली वो बोट देखता है और उसको लगता है कि मेरे लिए कोई तो बचाने वाला आ गया. On the other hand, if you see the person on the boat, he has been in the sea for many months and he has not seen the land. And suddenly he sees the person and he feels okay. मुझे कोई बचाने वाला हो गया. And none of them realize that both of them are in trouble still because there is no way out. So when we have no way out in cerebral palsy, we want to find certain answers. कई सवालों के जवाब जब चाहिए होते हैं तब हम लोग 3D gait analysis करते हैं. And one of the labs in country is at Jupiter Gate Lab. It is at Thane, जहाँ पे हम लोग 3D gait analysis करते हैं. The lab is open now, and with all precautions we are doing gait analysis. So 3D gait analysis क्या होता है? इसमें एक हॉल होता है, बच्चे के शरीर पे मार्कर्स लगाए जाते हैं, चिपकाए जाते हैं. There are cameras which can recognize these markers. And then there is a force plate which takes the force of the foot and ground reaction force, and then it can tell us how the child walks. So on the top you have a child walking as our mobile camera or a routine camera would see a child walking. But if you see through the eyes of gait analysis camera, this is how the child appears to be. So there is a model which is created and it tells us about the joint angles, it tells us about the forces, जिससे हमको ये जानने में सहायता मिलती है कि इस बालक का इलाज कैसे किया जाए, कौन सी सर्जरी करना चाहिए, कौन सी सर्जरी अवॉइड करना चाहिए, which therapy will work, how should we work on the pelvis, what is the right orthosis for the child. So ऐसे कई सवालों के जवाब हमको गेट एनालिसिस के जरिए मिल सकते हैं. So जब ये सवालों के जवाब हम लोगों ने गेट एनालिसिस के द्वारा इस चाइल्ड के लिए ढूंढे तो पता चला कि इसके हैमस्ट्रिंग टाइट थे, और जब इन हैमस्ट्रिंग्स को बहुत ही सलीके से हम लोगों ने लंबा किया, विद अ वेरी केयरफुल वे, this child could walk with straight knee, straight ankle and straight hip, because we had taken help of a technology to decide what is required to be done for the child. And this technology also allows us to document कि कितना फर्क पड़ा इस सर्जरी के बाद या थेरेपी के बाद या ऑर्थोसिस के बाद. So you can see the difference in the gait analysis before and after surgery. I'm not going into detail of this because that will be very technical, but everyone can see that the knee graph is at a different level here and now becomes completely changed. Okay, the ankle changes completely, and hip also has improved, though the surgery was done only on the knee joint. Okay, so there is something known as stiff knee gait. A lot of children with cerebral palsy walk with very stiff knee gait. And the question people many times ask, is it because of damage to the joint? इसलिए joint stiff हो जाता है या तो muscle की वजह से? And the answer is the stiff gaits are because of simultaneous contraction of muscles. So if there is a knee joint and flexors contract and extensors also contract at the same time, the joint cannot move. So it's like playing tug of war. If there is tug of war, the central rope doesn't move because the parties on both sides are moving and they are equally strong. So if you see a child like this, he's walking with his knees completely stiff, hardly any movement which is taking place, and he's looking down and walking. He may also have a sensory problem, but he realized that he had what is known as rectus tightness with a hamstring tightness, a stiff knee gait. And here you have to treat more than one muscles to manage the issue. Okay. So we come to the next poll question. All children with spasticity, do they need just medication or botulinum injection, or something else also will work? So I'm giving you a minute to answer this question. Is whether any other thing will work. Okay, is the answer yes or no? And the correct answer is that there are many ways to treat cerebral palsy. There are many ways to treat spasticity. It's not necessary that every child with spasticity has to have a surgery or Botox or surgery or medications. There are a number of ways, starting from physical therapy, occupational therapy, speech and language therapy, assistive technology, medications, and last thing is surgery for children with cerebral palsy who have difficulty in walking. And I'll give you an example here. This is a child who was walking like this, and someone had advised him that he should be given Botox injection to become better. But, we met up with our team of rehab, and then we just simply gave an orthosis, and his speed of walking, his balance improved. One must realize that, treatments like botulinum toxin or phenol injection, they will work for 6 to 9 months, and we sometimes need to repeat it. And it's very important to decide what time in the child's lifespan we should use these treatment methods. So don't do it very early. It's important that all your the whole team, the therapist, the PMR specialist, the orthopedician, orthopedic surgeon, neurologist, all discuss this problem together and decide when it should be done. And a lot of issues with cerebral palsy can be just treated or managed with rehab and orthosis. Not all of them require any intervention. Now, one more question again people ask is, do children with cerebral palsy have only spasticity, or there are other issues also they can have, other movement disorders? So I would like to say that a lot of children with cerebral palsy have dyskinesias, okay, which are dystonias and athetosis, and one should be very careful about that. So you see here on the left a child who has purposeless rhythmic movement. This is known as athetosis. And this is better managed with medications. Botox or surgery will not help this. And on the other side, you see a girl who has, again, a postural problem. And this is known as, this postural issue is known as dystonia. And this also should be managed with medications and therapy, and not really with botulinum toxin or any surgeries. Because these are movement disorders. And if you treat movement at one place, with injection or surgery, that movement disorder will be shifted to the other joint. And, one has to be careful. Another question is, if there is a contracture, is tendon lengthening the best way to treat? And the answer is no. If the muscle is short in CP, not the tendon. So tendon should never be elongated in CP, otherwise it will cause disasters. And strategy is very important here. For example, in a child like this is a girl who is walking on the outer border. So this is just looking from front. You don't have a complete picture. But what I notice here is mother is taking care of the child and father is away, folding his hand. So this is a social picture of cerebral palsy in India. And my dear friend, Dr. Sandeep Patwadan, often mentions that cerebral palsy is a social issue. More than body structure, function, contractures, what is important is activity and participation. How is the child able to manage? Is the child able to go places, able to go to school? Is the child happy? All these answers are more important than whether the child has hamstring contracture or a calf contracture. And these words, 5, 6 F words like fun, family, function, future, they have found a very important role now through international classification of function in management of cerebral palsy. So this same child, when you see from side, you can see her participation is very limited. The mother is tied up, she has to be with the child whole time. She doesn't have any future. So how can we improve the activity and participation of this child? And in this child, what we did, we found out that the muscles were contracted, they were tight. And we do a surgery called percutaneous myofascial lengthening, in which we don't do open surgery, but using a needle under ultrasound control, we elongate the muscle by cutting the fascia. So this is a percutaneous surgery. It's a day care procedure that doesn't have any scars, we don't take any sutures. There is no post-operative pain. And in this is how it is done. You can see this video that this is the calf muscle, and you can see the needle which is incising the calf muscle so that it can elongate. And this elongation you can measure very well on the ultrasound. Okay, so there is no radiation. This can be done in the OT, does not require any sutures. And a lot of our fellows are trained into this procedure. So this same child, you can see after 6 months after therapy, she is walking with plantigrade feet. Her knees are straight. Of course, she keeps her legs apart, which means there is some balance issue. We also know that left lower limb she is keeping in external rotation, but look at her participation and activity. She is now able to walk from point A to point B without her mother carrying. So that talks about her activity. And because of her walking better, she is able to now join school. So that talks about her participation. So her activity and participation has improved. And if you look at the family, how it has changed her environment, the mother has become free and father has come forward because he is looking at future in this child. So looking at 6 F words in this child, it's apparent that activity, participation, and family and environment of the child has changed because of this procedure, not just knee angles and ankle angles. And this is something which is very important to realize. Again, it's a debate that spastic muscles should be strengthened or should be weakened, because when we inject Botox, they become weaker, but when we do functional therapy, they become stronger. And the answer is that spastic muscles are actually weaker. And strength training program is a very, very important part of cerebral palsy therapy. There are certain structures which get over-lengthened. For example, quadriceps, hip extensor muscles, they are weak in CP, and it's important that we have a special exercise program to strengthen these muscles so that these muscles can be strengthened and we can help the child to become a stronger person. And I'm sure Dr. Kanan Doshi, Tasya Rakshita, Dr. Medni Pate, and all the other therapists who are present here will agree with me, and I would need their comments at end of my talk as to, what are the components of therapy in cerebral palsy. Now, for a child with CP like this, who has hip issues with scissoring, what is the first thing you will do? Therapy, splint, surgery, or X-rays? And the answer is then that when you see a child like this who has scissoring, the first thing you should do is get X-ray of the hip, and this is known as hip surveillance, because a lot of children with cerebral palsy have a silent spastic hip disease. Okay, and if you don't X-ray them well in time, then you will miss the hip dislocation and miss the right time to treat these children with orthosis or botulinum toxin or a very small surgery. Once the hip dislocates, it requires a very big surgery. Child is very painful and it's difficult to treat. So it's very important to take X-ray of hip for every child with cerebral palsy once a year till the time the child gets matured, and then calculate what is known as migration index. And the last question I want to ask is, do children with CP just need a good pediatric orthopedic surgeon or a good neurologist? And the answer is no. CP is a team game. Like cricket, you require 11 people to catch cricket. You require people, and I can list here pediatric neurologists, orthopedic surgeon, neurosurgeons, and child psychiatrists. So these are all doctors. You will go to physiotherapists, occupational therapists, speech therapists. These are the therapists you will go to. You may also need to go to orthoticians for splints, physiatrists, child psychologists, special educators, and teachers. So they all manage it together along with the parents. Parent is a very important part of a team to manage cerebral palsy. And we want to empower parents, especially in this pandemic area. It's been essential that parents become the central axis of treatment. जो parents जो है उनको बहुत शक्तिशाली बलवान बनाया जाए, उनके हाथ में सत्ता दी जाए कि वो लोग थेरेपिस्ट और डॉक्टर्स के सहायता से अपने बालक का भविष्य सुधार सकें. And this is the concept which is very, very important in cerebral palsy. Teamwork is important. I want to thank Dr. Chasnal Rathod, Dr. Jaideep Damede, who are working with me at Jupiter CP Clinic and at SRCC Children's Hospital. And because of the team, we are able to manage treating so many children. And with this, I'm going to stop here and stop my presentation. Is 11:39. And I want to keep this forum open for discussion. I think people can sort of now keep their videos on, and if there are questions, please you can type in the chat box or you can unmute yourself and ask. And I would sort of request Dr. Tasya Rakshita to moderate this question and answer session. So till the time questions come in, if Dr. Kanan Doshi, if she is here, I would request her to unmute herself. Kanan, can you tell our parents and therapists about what are do's and don'ts in therapy? What are the wrong things which are commonly done, and what are the right things should be done for therapy? Dr. Kanan Doshi is a neurodevelopment therapist from Ghatkopar, like Dr. Tasya Rakshita. She is also Dr. Medni. I'm trained with her, and we have had a lot of success stories with Kanan, a lot of families. And what I really enjoy working with her is that we all work as the same family, along with the family. So there is no hierarchy. So Kanan, over to you. Please tell us.
There are few things. Giving right kind of orthosis and at the right time, because so many times we just give AFO to control gait. I mean, to control TA tightness or TA spasticity, and it just doesn't work. You come with hip and knee and tightnesses over the period of time, they get tight. The ankle remains on the child is walking with the flat ankle and hip and knee has gone tight. At times I feel it's okay to let go of that ankle and manage hip and knee better, so that later on when they need corrective surgery, we can just do it on ankle. Because then that helps on trunk also. Because your trunk, hip, knee is better, you just need to correct the ankle and child will be good. So that is one part. So prescribing AFOs and the parents, I know very very difficult for parents, very to maintain consistency in therapy. But I feel if they do it, it really gives good results. For first 7 to 8 years, if they do it consistently, later on the need of therapy comes down and you can manage them at home also. We have done that also. So yes, those are the things I feel they should. Hello.
So There is a question here that what are all the ways we maintain muscle length? I would ask Dr. Tasya Rakshita first, if you can explain as a therapist, how do you maintain muscle length and what is the role of orthosis? And then I will explain what are other ways, by way of intervention to maintain the muscle length. So we'll take this question right now.
In previous therapies, we are doing lots of stretches for maintain length of the muscle. But now with the new therapies, we are trying doing with functional activities. Suppose hamstring is stretched. अगर आप hamstring को stretch करना चाह रहे हैं, तो hamstring को stretch करने की जगह उसको एक functional movement में आप बिठाएं, and then do some activities on it. For an example, you can a child is able, grade 3 उसका अगर आ रहा है, child खड़ा हो सकता है with support even, तो आप उसको बास्केटबॉल खिला सकते हो, आप उसको योगा आसनास दे सकते हो. फंक्शनल मूवमेंट में आपका जितना हो सके आप वो स्ट्रेचिंग दीजिए. दैट विल बी मच बेटर. देन टू मेंटेन दैट यू कैन यूज AFOs or the supporters. Kinesio tape is there, Fabriform is there, and along with that, of course, Dr. Taral is there, who is giving you a good length of the muscle, and then you can approach for the good therapies after that or before also. Sir, over to you.
Yeah, absolutely. So,
anyone want to add?
So what I would say is,
Can I add one more thing?
Yeah, please, Kanan, please add.
The other way of maintaining the length is also strengthening the antagonist. If you strengthen the antagonist, the muscle that has been operated will help in maintaining the length of the agonist, because there will be less need for that muscle to shorten as his antagonist is working strongly. So like if you have done hamstring tightness, hamstring release, you have to strengthen quadriceps very strongly in your therapy, and of course you are strengthening hamstring itself. That will help you maintain the length.
Very true. Very true. We need to.
Okay, so one thing I would like to mention is, one should know when not to lengthen. So there are a lot of children who are walking on toes, and that calf gives rise to propulsion. And if you take away the calf's shortening, the shortening is powerful in those children. So if you take away the shortening and over lengthen the muscle, they will result in crouch gait. Similarly, there are a lot of children, where child is walking with knees bent, and then they undergo hamstring lengthening surgery. Sometimes people just release all the hamstring to get the knee straight, and that decreases, that completely sort of releases also the hip control power which the hamstring have. And these are the children who are walking independently, running around, suddenly walk with walker or require KF or orthosis. So it must be realized that cerebral palsy is an issue of spasticity, muscle tone. Muscle contracture is a secondary problem, and over lengthening of muscles, over stretching of muscles has to be avoided at all costs. And one has to learn to manage muscles, very judiciously, with a lot of care and with a lot of smartness. So that's why the title of this talk is Thinking Smart in Management of Cerebral Palsy. And one thing I want to say to all the therapists, that if you're not sure, when you don't treat cerebral palsy regularly, you treat only few of the patients. If you're not sure, please talk to a senior therapist and who's managing more pediatric patients. Talk to them, and I'm sure they are available to guide you all the time. But things, once they go wrong, it's very difficult to correct. And when things go in a proper manner, it may take a little more time. There is time for everything in cerebral palsy, so one should not bypass those lines. When you bypass the lines, the issues may actually exaggerate. So one question which is from a parent is that after surgery, how many years the muscle will remain straight or elongated, because the child is also increasing in height. So it's like that. I'll give you a very simple example that I am doing a job somewhere, and then I ask for a pay raise, and my pay is increased from 3 to 4,000, and I'm very happy. But after 2 years, that raise is not going to be sufficient, because the expenses have increased, right? So this is a very important question, that for how many years the muscle lengthening will work. The answer is that if it's done at aponeurotic level, and if your therapy, including functional therapy, continues, and as Dr. Kannan said, the antagonists are also strengthened. So if the child has hamstring contracture, hamstring lengthening is done, but at the same time, if quadriceps are strengthened, then the chances that there will be a repeat contracture is very, very less. It will not happen. And we have a lot of patients with Tasya Rakshita, with Dr. Kanan Doshi, with Dr. Medni Pade, some other therapists here, who have gone over a period of 10 years, 12 years, 15 years. They continue to do well if the principles are followed. So the principles to be followed are not to do surgery at very young age, treat with therapy. Do surgery at the right age, the right dosage, the right age, and by the right person in the right manner is very, very important. Any other additions from Kanan or Tasya Rakshita from you about this?
The other thing, recently, over the period of time, I have seen cerebral palsy changing, or I have seen my thinking changing. But the thing is, the sensory problems in managing CP has changed has given us so much different view. I have made changes in my therapy. I have included sensory integration in my therapy, and the results are better. So I think before going for surgery also, we should think about sensory integration, because they have different sensory deficits.
So this is absolutely right, and I agree with it. I just had a person to repair AC who came to my place, and we all thought there is something wrong with the compressor, and he said there is nothing wrong with the compressor, the sensor is wrong. So this is exactly about sensory therapy. Before you touch the muscles, make sure the postural control, the biofeedback, and the sensations.
They also have sensory processing disorders.
Yes.
Secondary processing disorder. And post, if we make them go through that surgery with that kind of progressive disorder, they come with shock. It becomes, they take time to cover from that sensory part, but then we lose the time on strengthening the muscles. Right. So I don't know, but yes, putting them on sensory integration has helped me a lot in treating my CPs over last few years, definitely.
So one question is, who should do sensory therapy? Is it OT or PT or any child therapy? It has to be part of any therapy for a child. I want Tasya Rakshita to answer that, and then Kanan, you can help.
Who does their sensory?
You have to talk a little louder. We can't hear you.
Yeah, this is very much important that you will done your sensory. This is a special course or things which you have to learn. It is not about the physiotherapist. It's not about the occupational therapist or a sensory integrated therapist. It's moreover who know about the sensory things. Then only, and I want to add one more thing about the previous question, which is after surgery, how many years the muscle will remain. It is all about pre and the post consult with the doctor and the therapist of a patient. Because most of the time what we see, हमने सर्जरी करवा ली है, हमें या डॉक्टर ने प्रॉपर वो बता दिया है, उसके बाद भी हमें थेरेपी बहुत बाद में शुरू की है, तो हमारा जो जितना किया था उतना रिमेन नहीं रहता है, और फिर सेंसरी पार्ट हम पहले भी देखते हैं और बाद में भी देखते हैं. दैट इज ट्रू, बट वी नीड टू बी ऑन टाइम. This is for the parent I'm talking about, because they have to come on the same time when they approach for the surgery, pre and the post. Both they have to do. Then only they can maintain for a longer period.
So I agree that a reference to therapist has to be before surgery, much before surgery, rather than operating and sending to therapy. That's not the right approach. What I want to ask, a lot of our parents don't know much about sensory integration. So Kanan, kya karwate hain? Many sensory, and what parents can do right now, in a lockdown when they are at home, the child is at home and they are not able to come for therapy. What are small little things they can do at home to improve the child's sensory perception?
See, what happens is in the NDT, we do the goals are strengthening, stretching, maintaining, and then you put it in function. But when the time comes to put it in function, that's where the sensory integration is needed. They cannot put it appropriately in function. भी स्ट्रेंथ 4 है, लेकिन वो गेट में नहीं दिख रहा है. अरे क्यों नहीं दिख रहा है? 4 है तो दिखना चाहिए, राइट? पर नहीं दिख रहा है. So after that we started giving them in sensory integration, lot of proprioceptive, tactile and vestibular input in functional in our therapy, and then they started moving better. Their confidence increased, basically. They started doing things much better because they could use their body well.
So one question which is important is which has been can we give strengthening for spastic muscles as they are weak? Will they become more spastic after strengthening? So I want Kanan and Rakshita both to answer, and then I'll give some surgeons' point of view after that.
No, I think we should strengthen spastic muscle. They are weak. They will not become, but in a correct way, in proper alignment. If you are just going to strengthen them in a bad alignment, then they will become spastic, because then they are going to use spasticity instead of strength.
So a lot of time I've seen, there are a lot of trainers will come into picture and they will, strengthen all muscles. It is not necessary. You have to know which muscles to strengthen.
Yeah.
And are you going to increase the endurance or strength? That is also important. Both are completely different.
Yes.
Okay, so
as Kanan ma'am said previously, we have to put in a functional movement with the sensory.
Yes.
So when you are going for the strengthening of a weak muscle, then you need to think about that which is weak and how we can upgrade that. Absolutely. In a functional movement with sensory.
And in phase. So which phase of the gait cycle that muscle has to be utilized? So suppose we strengthen quadriceps, it should be utilized in the swing phase and when in the mid stance phase. But if it gets strengthened in the wrong phase, then it will have a deleterious effect. So it's very important that the strengthening is also done in the functional way, so that the muscle uses the strength in the right phase. And these all things are very, very important for people to be realized. So these are all principles. Yes, Kanan, please say.
That is what we are saying when it comes to sensory involvement.
Yes.
Because they just don't understand where to use muscle or how do I use my body to perform this function.
I'll give a very simple example that, if you strengthen the grip, but do not train the child to release it, he can't hold anything. So you have to teach how to strengthen the grip and then release. At what phase, what muscle has to act. That is also very important to, train the child for. So we have around 3 to 4 minutes left. I think Ritika has a question that what can be best done through therapy to stop the left knee from moving inwards. I think so that can be done by strengthening the quadriceps and the abductors, quadriceps, and the tensor fasciae lata. okay, and IT band. So there are muscles which need to be strengthened in that case.
And core, very important.
Core is very important. Yeah. So you cannot forget core, because for walking, it's important that core, the balance comes from the core. So core is weak, your nothing is going to work very well. So Ritika, I hope it answers your question.
You need to analyze why that knee is going inwards.
Right.
Why? Because the abductors are weak, or the adductors are tight, or the core is weak, or quadriceps are weak. You need to analyze that and then attend to that child. Like if I'm working on quadriceps, but I'm not working on gluteals, so the results will not come if the gluteals are weak.
Right.
And after that, maintaining also very important to maintain that.
Maintenance is also very important. So you achieve something and you maintain it. Maintenance is equally important. And maintenance is difficult because child is growing all the time, increasing in length, putting on weight. So, all these issues are very, very important. And this age group, again, we want to mention the transition age group is very important because that's the time when hormonal changes are occurring. So if you utilize the transition age in the right way, you can improve the muscle strength. You can improve the vigor in the child. But if you allow the child to put on weight and then, parents will say, abhi 8th ka exam hai, 9th ka exam hai, 10th ka exam hai, and therapy band karo, then the child can become worse. So, I've seen so many children doing so well till age of, 10, 9, but then, once the height increases, they become more busy. Many of them do stop walking, and we have seen this happening. And I would tell parents that take care of the transition ages very well. You need to take care of vitamin D, calcium, and so many things. So what we have learned today, हम लोगों ने आज क्या सीखा? आज जो फिजियो स्पर्श, ऑर्थो टीवी, फिजियो टीवी और इंस्टीट्यूट ऑफ पीडियाट्रिक ऑर्थोपेडिक डिसऑर्डर्स और जुपिटर सीपी क्लिनिक के माध्यम से आज जो whatever 1 hour session we have had, lot of things have become clear and what is to be done and not to be done in cerebral palsy. So पहली चीज जो हमने सीखी कि जो चाइल्ड टाइटनेस के साथ चलता है सबको सीपी होना जरूरी नहीं है. They can also have some other issues like spine problem or they can have a hereditary neurological problem. तो उसके लिए evaluation होना जरूरी है. पीडियाट्रिक न्यूरोलॉजिस्ट या ऑर्थोपेडिक को सर्जन को दिखा के ये क्यों हो रहा है ये जानना जरूरी है. यदि MRI करना है ब्रेन का तो 2 साल की उम्र पे करना जरूरी है. It is not necessary that every child with CP require genetic tests because they are very expensive, but some of them may require. So that is first about diagnosis. दूसरी चीज हम लोगों ने सीखी कि there is interdependence between hip, knee, ankle. तो वो भी देखना बहुत जरूरी है. मसल्स जो है वो वीक हो जाते हैं सेरेब्रल पॉल्सी में, उसका भी ध्यान रखना जरूरी है. लिवर आर्म डिसऑर्डर्स होता है, उसका भी ध्यान रखना जरूरी है. बच्चे को स्पास्टिसिटी है, कॉन्ट्रैक्चर है या लिवर आर्म प्रॉब्लम है, वो भी देखना जरूरी है. और यदि ट्रीटमेंट जो होती है ये सब जानकर और थेरेपिस्ट और डॉक्टर्स के बीच में डिस्कशन हो के यदि तय की जाए और जिसमें ज़रूरी है उसी में गेट एनालिसिस भी किया जाए, then we can treat the children with CP in a better manner. So this was just a preliminary discussion and I'm sure that if people like it, please write to us. आपको ये प्रोग्राम कैसे पसंद आया? If you like it, we will carry on more sort of episodes with different experts, with Physio Sparsh and with Physio TV, with help of everybody, so that people all across the country and even other countries can benefit from these talks. Anything, Tasya Rakshita, you want to say anything when we end?
Yeah, thank you so much, sir. First of all, about everything. जब भी तरल सर जयपुर आते हैं और बच्चों को ट्रीट करते हैं, इट्स ऑलवेज अ प्लेजर एंड आई ऑलवेज लर्न समथिंग न्यू विच इज अ वेरी गुड थिंग फ्रॉम हिम. एंड थैंक यू कानन मैम, बी अ पार्ट ऑफ दिस. आई मेट यू फर्स्ट टाइम but I don't feel so. Thank you so much. And Dr. Ashok, who entirely did everything behind us, And I hope Taral sir is always give a chance to meet again and again.
Yes.
So we'll